Hello everybody. I'm happy to introduce Laurin Burla, who is a resident in the 4th year, and we worked about the topic of evidence of perioperative surgical antimicrobial prophylaxis. I'm very proud to introduce Stefan Kuster. He's here as well. He's very much involved in the Swiss group, in the Swiss NOSO group, and prepares the guideline. And of course, he also prepared the internal US set guidelines about antibiotics, prophylaxis and therapy. Please.
Morning and welcome everyone to our presentation. So what do we want to prevent with perioperative antibiotic prophylaxis? The surgical infections, especially the surgical site infections. It's not only an important concern to us, but it's also a global concern. It's a content of a big campaign of the World Health Organization. Of course, in the beginning, I need to say it's not only about antibiotic prophylaxis, if somebody develops a wound infection or not. We have different pathologies, surgeries, and many other influencing aspects. On the hospital side, we have instruments, sterilization, the OR, all the hygienic standard measures, experience of the surgeon and his team. On the side of the patient, we have comorbidities, we have concomitant infections, we have colonization with resistant pathogens, and we have co-diseases like diabetes mellitus, age, obesity, and so on. But let's focus today on something that we can optimize on an everyday basis as treating physicians. 38% of nosocomial infections are due to surgical site infections. That means that in 2 to 5% of every surgical procedure, a patient develops a surgical site infection. It's 1 out of 24. We need to distinguish a little bit worldwide. We have, on the one hand, we have our high-income countries, and on the other hand, we have the low and middle-income countries where the risk to develop a surgical site infection is 3 to 5 times higher. So in our countries, it's not really, or let's say a normal surgical site infection is not really a life-threatening condition, but it's a matter of morbidity, costs, and hospital days. The Department of Infectious Diseases conducted on the 25th of April 2019 a point prevalence survey. At this day, we had 790 patients in this hospital hospitalized. 5.9% of them had an hospital-acquired infection. Surgical site infections were responsible for 42% of these infections. So among all the patients, 2.4% had on this day or been treated on this day because of a surgical site infection. There are two major subgroups of surgical site infections. The one are the organ and space, so the deep infections, for example, a big abscess in the abdomen after surgery, responsible for 30% of surgical site infections and for 90% of mortality. The other group, and that's the group we're going to talk about today, are the incisional surgical site infections, so the superficial skin, subcutaneous tissue, and the deep soft tissues, muscle and fascia. The goal of the perioperative antibiotic prophylaxis is to reduce the burden of microorganisms at wound site. And to define surgical site infections, it's not always that easy. There are different, or let's say there's more than one definition. It can be a purulent exudate from a surgical site or a positive culture from a wound that was primarily closed, or a reopening because of a sign of an infection, or if the surgeon himself positions the diagnosis within 30 days after surgery, or when we have some prosthetic material, then up to 90 days after surgery. Of course, not every wound is the same. So there are 4 major wound types. They stand also for the surgical procedure behind them. It's clean, contaminated, and dirty. And that's important because they have a completely different necessity for antibiotic prophylaxis. I would like to ask the residents, can you maybe tell me an example for each of these types of wounds?
Hernia surgery without involving the bowel, for example?
That would be a clean procedure, yes. Maybe some example for a clean contaminated.
Laparoscopic appendectomy, maybe.
Yeah, that's correct. That would be an example for this one. I will show you some more examples. So let's start with the clean wounds, the clean surgical procedures. These are elective, non-traumatic procedures where we have no inflammation or contamination. We do not open any, for example, intestinal organ, and we have no break in aseptic technique. An example would be a thyroidectomy or a hernioplasty. The second group are clean contaminated procedures. This is mostly an elective procedure, can also be an emergency procedure, but it's a controlled opening of an organ. In our case of the gastrointestinal organs, we have a minimal spillage and a minor break in aseptic technique. Example here would be a lap chole or a laparoscopic appendectomy without any perforation or fluid. The third group, it's something in between the clean contaminated and dirty procedures, not always that clear, is the contaminated group, where we have a gross spillage, we have an acute but non-purulent inflammation, and we have a major break in aseptic technique. Example could be an acute diverticulitis surgery, but without any fecal or purulent peritonitis. And the fourth group, the most severe type of surgery and wounds, is the dirty group. We have an active infection, we have a purulent or a fecal exudate or a severe trauma, for example here a stab wound. Yes. As I said before, these four wound types are important because they have completely different risk or percentage for developing wound infections. The clean ones are from 1 to 3%, the clean contaminated ones from 2 to 7%, contaminated 6 to 15%, and the dirty wounds have a risk 7 to 40%. Here it's important to mention that today we're going to speak about the clean and clean contaminated procedures, because the contaminated and the dirty procedures, there we don't ask ourselves if we need any antibiotic prophylaxis. They need antibiotic therapy, so this is another topic. The major group where perioperative antibiotic prophylaxis is indicated, where we have a good evidence, are clean contaminated procedures. There, to repeat, we have a controlled opening of an organ, for example in the gastrointestinal tract, and we're dealing with polymicrobial flora, so with E. coli, Enterobacter, Enterococcus, and so on. To mention some examples, the uncomplicated appendicitis, there we have good evidence and good data that perioperative antibiotic prophylaxis can significantly reduce the percentage of wound infections, so here it's recommended. And we have the small intestine procedures. There we have no randomized controlled trials so far, but the risk for surgical site infections is high with 8%. Here it's recommended. We use usually in this hospital the second generation cephalosporins. There are two exceptions. If we have an intestinal obstruction or a small to large bowel anastomosis, then we should combine it with metronidazole to cover the anaerobic germs. So what's about the other group, the clean wounds, the clean procedures? There we have no opening of any organ. We're dealing with skin flora, and the percentage of surgical site infections is generally really low. It's between 1 and 3%. In this group, in most of the cases, there is no evidence that would recommend any antibiotic prophylaxis. I'd like to show an example: head and neck surgery, so thyroidectomy, parathyroidectomy, and lymph node excisions. There we have one randomized controlled trial with 500 patients. The percentage of surgical site infections were 1%, and there was no significant difference. So here it's not recommended. Another procedure, it's a bit an exception, is the elective laparoscopic cholecystectomy, where we have no inflammation. This is actually a clean contaminated procedure, but several randomized controlled trials couldn't show any benefit, so here it's neither recommended. And a third example, it's actually a clean procedure, inguinal hernia surgery, but there we have a big Cochrane meta-analysis that could show that there is a significant reduction with perioperative antibiotic prophylaxis of surgical site infections. So here it's generally recommended. And that's due to two reasons. One is in adult surgery, at least, we often have foreign material, and the other reason is the surgery is performed in the groin region, where it's a bit a higher risk for wound infections. So if we talk about antibiotic prophylaxis, we need to ask ourselves, how is the correct application? And there are some aspects: is the dose, timing, repetition, duration. Normally, we give the agent intravenously, because like this we can achieve the best blood concentration. The definition of antibiotic prophylaxis is one dose, 1 hour before surgery or within 1 hour before surgery, and if surgery lasts more than 4 hours, we should repeat it. There is no evidence for antibiotic prophylaxis because of drainage systems. According to the current literature and the clinical practice guidelines for antimicrobial prophylaxis and surgery, the so-called Bretzler guidelines, there is currently no gastrointestinal surgery where postoperative prophylaxis is advisable. Question for the residents: what do you think, what is the major argument against inappropriate use of antibiotics?
Antibiotic resistance?
Yes, that's correct. And here I think it's important to mention that even if we have no evidence for a procedure, but we give one single shot, we think that this is normally not the major problem. The problem is an inappropriate prolonged prophylaxis, because this leads to a decrease of the patient's own flora, to a decrease of his immune defense, and to an increase of the risk of a contamination with resistant pathogens. We have guidelines of the European and the US Center of Disease Controls. They do not recommend any prolonged antibiotic prophylaxis after wound closure, even if a drainage is placed. And the same is also a statement of the World Health Organization. If we remember our grandfather Hippocrates, antibiotic resistances are a major problem worldwide. That's in the United States, 35 deaths every year through antibiotic-resistant germs. Also in Switzerland, this problem is on the rise. It's a big concern also for the Swiss state that published the Swiss Antibiotic Resistance Report in 2018. To conclude, I want to say that with an appropriate use of perioperative antibiotic prophylaxis, we can help to prevent and minimize surgical site infections and prevent morbidity and mortality, reduce hospital duration and costs. It needs a strict indication and a short duration, and never forget to check the local guidelines because they can differ in between hospital and regions. Yes, and I would like to end my presentation with a phrase of G. E. Lessing from the 18th century that should remind us to always think about and reassess our actions. Thank you very much for your attention.
Thank you, Lauren. Very important topic here for many reasons. I think you highlight that well, and one is certainly at the end cost. I mean, the antibiotic, it's very expensive if it's not used properly, and not only that, but you can have more problems in that. So maybe one question to our specialist here in some way. The timing, I mean, seems to be very important. I mean, I think this is one area when we need guidelines and people need to comply with the the guidelines. I hope we do it. So my first question, what is your assessment here in surgery? Do we comply with the guidelines? How many times we do not comply? I think that would be good for us to know. And next, the timing. If normally anesthesia is done an hour, exactly an hour. If we forget this, does that make sense to still give it at the time of the incision? Or anyway, here there is really no advantage. Should we just omit to do it if we don't have the correct time?
So regarding your first question in terms of compliance is generally good, I would say. What I see in daily business is that prolonged prophylaxis is an issue. There's quite a big amount of patients who receive prolonged prophylaxis, which would not be indicated, I guess. In terms of the timing, about 70 to 75% of all our patients receive their prophylaxis within the 60 minutes before incision, which is good. If you forget it, ideally you would give it, wait until everything is in the patient and then do the incision if there is those 5 minutes. It's far better to do it shortly before the incision than at incision or after incision. There's no benefit if you do it after incision.
We always focus on surgical site infection, but this is really not the major burden. I mean, people don't die because of surgical site infection. They die because of sepsis. They die of uncontrolled infection. So why we look really on this outcome measure, and perhaps in this institution we have much other problems with infections, not surgical site infections. Is this just a mirror of what happens in general, or what is your opinion?
Surgical site infections are mainly a quality indicator, and if you're saying that it's not a problem in your department, this is great because you have high quality surgery that you're performing. But there is institutions that have a problem with surgical site infections, and for those, I think even in Switzerland, it is a quality indicator that should be focused on. But I agree with you that in general, there is not so much harm for the patient due to surgical site infection, but there is harm for the institution because of extension of their hospital stay.
I agree with you, it's a quality measurement, but people die here not because of surgical site infection. So if we spoke about morbidity and mortality, so I think we have to keep this in mind, and they use always this outcome measure, and this is not really the problem and issue, right? Why people die in our institution. I mean, they are immunosuppressed, they might have a surgical site infection, but this is not the infection which basically kills patients in the majority. So, but I agree with you, it's an outcome measure here.
May I maybe also add something from because what we also have to focus on is on the correct giving of antimicrobial prophylaxis. So if we do a prolongation of it, we do put the patients at risk for colonization with resistant microbiotics. So there is a life-threatening risk then, not because of the surgical site infection, but if we put them at the risk for another colonization by inappropriate use of antimicrobiotics. That's the focus a little bit.
Well, this is used everywhere, this quality measurement, I mean, as a surrogate marker of whatever, and we are subjected to that, and we, the CEO and others would inform us and to correct. I think it's okay. I mean, we always a bit wonder the exact relevance, but obviously this is something we can compare. Just one question, I mean, one country which has absolutely abused antibiotics, they're out of control, is India. And I would love to have, because we heard that many times, and it was a couple of times, and they cannot control that. They use antibiotics for absolutely everything. So they have resistant bugs, and surgery is a nightmare in India. How can they be out of this now? Is that possible, or should you stop giving antibiotics? Just for my interest, would like to know if you know the situation in India.
That's a great question. I think that's one of the major health threats for global society in the next 25 to 30 years. You don't have to go to India. You can go to Italy. Northern Italy has the same problem, and for bowel surgery, it's a real problem. So if you have 20% of the population colonized in the intestine with carbapenemase-resistant germs, so what can you do with your antibiotics prophylaxis? So a regular E. coli is no longer covered by regular prophylaxis, so that's a real issue. Has not been studied properly, but nobody actually knows what to do with that.
So we need to give up.
We need to develop better and more antibiotics, and use antibiotics wisely as long as we still can. So not give carbapenems if you really don't need to give them, especially not for prolonged prophylaxis after surgery.
Thank you very much. Great talk. Just quick question to the clean surgeries, especially thyroidectomies. Was there a difference in the length of surgery? Like if you do a lymphadenectomy, the surgery will be much longer. Were those also did not profit from a prophylactic antibiotic?
I'm not aware of any high quality studies studying this question. So these topics are generally understudied because nobody wants to do those randomized controlled trials. But in general, you can say there's no benefit of prophylaxis in clean surgeries unless there is those that we saw. So even if prolonged.
Thank you very much. Just two brief questions. One is, do we have internal guidelines for prophylaxis? We have guidelines for therapy, but I'm not aware of internal guidelines for prophylaxis.
We do have those guidelines. It's in our antibiotic booklet, pages 94 to 96 or something like that. So there are.
And secondly, there's a number of cases that don't quite fall into the four categories that you have shown. There is rectal cancer surgery where you have clean contaminated, which takes several hours, and the surgery may not be comparable to a simple small bowel resection. Numerous large-scale institutions use 24-hour prophylaxis for such cases. What is your opinion on that, and what do the data say?
Well, regarding the data, as I said, those topics are understudied, especially for those special cases. There's no clear black and white. As always in medicine, there's a lot of gray. My personal opinion is that I truly believe that only for certain cardiothoracic procedures there is a gray zone where you could use prophylaxis for after surgery, so for 24 to 48 hours, but I'm not aware of any studies in abdominal surgery that would support extension of prophylaxis beyond surgery.
In the newspaper I've read that the cattle use of antibiotics in cattle is a huge problem worldwide. Would you lose a word on this?
It's a huge problem, yes. It's not in Switzerland because antibiotic use in animals is prohibited if you use it as a growth promoters. But in the US they do that, and worldwide they do that. In Switzerland I learned that they use colistin. You may be aware that colistin is used as our last resort antibiotics for some of our patients in ICUs. In Switzerland, they use colistin for small piglets because otherwise they die from infections, and with colistin they survive. So we have our problems as well.